are looking to seek credit for. If you have not completed all the steps, we will not be able to issue the credits, as those are the standards that JCAPO and AOA hold us to. If you've previously received credit for this session, we would not be able to provide credit again, as it's the same program and presentation that you have received credit for. So also, as per the usual, for those of you who are not seeking credits, you can just learn and enjoy with us. If you have any questions about tech training, about credits, or anything else that we can help you with, please reach out to Jamie Anderson, and her email is in the chat. Today's topic is visual fields and tonometry. That is led by Dr. Justin Schweitzer. If you have any questions throughout the presentation, please type them into the Q&A function in Zoom, and he will be sure to answer them. Dr. Schweitzer, go ahead and take it away.
Great, thanks so much. I'm going to go ahead and get this screen shared. And happy Friday to everyone. And please utilize that chat area. I will be watching that, so don't hesitate to send some messages if you have questions as we get through this. I hope many of you are getting ready to be back in clinic or have already started being in clinic. I know I'm antsy, and I had a chance a few weeks ago to get in for a little while, and now looking forward to being in there more often starting up. So let me just see here. I think I got everything I wanted. I'm gonna go ahead and start my video so you guys can see me. And we're rolling. All right. So as you guys can tell, the topic today is going to be visual fields and tonometry. And my goal with this is really to take you through some definitions on visual fields. We'll touch on how to read a visual field, because I think it's important to at least understand what you're looking at. I understand you're not going to be interpreting them or documenting that, but to have knowledge on how to read them is important, because many times, as you guys know, patients taking visual fields, it's a challenge. It's not easy for patients, and so we need to make sure that they're accurate. And just by being able to understand the accuracies of the visual field, what parameters you should be looking at, you can make the life of your doctors easier, but you also can make the life of the patient better too, because there's no reason to continue to do visual fields that are inaccurate. I'm also going to talk about some newer technology that's out there to make our visual fields more accurate. There's some virtual reality technology that's starting to be utilized that I've had a chance to get my hands on and use quite a bit so far here recently, especially with COVID-19 things going on, which is fascinating. And there's some data to back that up as well. And I'll share that with you also. And then we'll jump into tonometry, and we'll talk a little bit about different options for tonometry. I'll give you a little update on what disinfecting protocols are being talked about from the American Academy of Ophthalmology as well as the AOA. And then also talk a little bit about some of the papers that have recently been published on, COVID-19, and is it in the tears? Is it on the conjunctiva of the lids? How careful do we have to be around that? And there is a bunch of papers that have come out on that recently, as early as February of 2020 and even March, and more of this is going to keep coming out. So what you hear from me today will probably be out of date by a month from now, because new stuff will come out. A lot of the data I'm going to talk about in regards to that is coming from China, where this all obviously first kind of started to occur. So they have the studies to kind of show and share with us, and so we'll dive into that as well. But again, don't hesitate to ask questions. I'm hoping that there's a few questions in the box. If not, maybe I'll shoot a few questions to you guys as we go through this. So let's see, now my advancer isn't wanting to work. 1 second, guys. All right, we're back. So definitions. Right off the bat, I think these are important definitions to know, to understand. When we look at the different definitions out there, the visual field, what is it? It's everything that's visible at a single time from one eye. So when we do visual fields, you guys all know and understand that they need to be done individually. If we do both eyes at the same time, we're going to pick up different things. The one eye, the right eye is going to pick up things for the left eye. The left eye is going to pick up things for the right eye. So keep that in mind. Whenever you do a visual field, doesn't matter if it's an Amsler grid, doesn't matter if it's confrontational fields or your Humphrey fields, you got to have it so one eye is covered, switch it, and then the other eye is covered. The visual pathway, we'll talk a little bit about that. That's talking more neurological. It's the route of visual information from the retina to the brain. The physiological blind spot, you find that in every single patient that we do a visual field on. It's the optic nerve head, and you're going to see that defect, that scotoma, on every single visual field as long as it's done correctly. And then finally, what is a decibel? It's a unit of brightness. So the higher that number, the dimmer the lights. So when a patient is taking a visual field and we look at the printout, you'll see decibels of 32, 28, 20, 18. The higher that number, the dimmer the light. We want that number to be higher because that means the patient's picking up that dim light. They're most sensitive to it. That number that's really low, if it's a 0, for example, that means the brightest light was shined at them and they were unable to see that. So keep that in mind as well. So when we think about the different definitions, kinetic perimetry, static perimetry, a variety of different things, what we're going to focus on today is more static perimetry. Now, some of you may be doing kinetic. We don't do any kinetic in our practice. It takes a long time. As a student, I did some kinetic, so Goldman, tangent screen, those types of things. But we don't do those in our practices. Typically, they're just not accurate, or excuse me, I shouldn't say accurate. They're just not efficient. And so most of the perimeters that we use are static perimeters. This would be your Humphrey field, your octopus, FDTs. There's a variety of different ones, but those are your static perimeters that we're talking about. A few more definitions. What is a scotoma? Scotoma is an area of reduced sensitivity to light. Okay, so you can characterize scotomas as being absolute scotomas. That's if you have a level of 0. Okay, that means the patient is unable to sense any light at all. Or you can have a relative scotoma, which is an area that senses light, but it could be less. Earlier I was talking about if you see a number of 32, for example, that's a very dim light, they don't have a scotoma in that area. But if it's, say, a decibel of 14 or 1, then a scotoma is going to show up there, and it can be a relative one or it can be absolute if it's 0. So they're labeled as either shallow or deep. That's what a scotoma is. And then we also label them, and you'll see this written on visual fields quite often, is the location of it. Is it central? Is it paracentral? Is it a nasal step arcuate? And I'll share a few of those examples with you here in a second. So what is a visual field for? Well, we think of it as a way to identify vision loss. And this can be used for what we're going to talk about mostly here is glaucoma, but it also can be used for situations where we're looking for something neurological, pituitary adenomas, a lesion in the brain, and we run different visual fields for different situations. For glaucoma, it's traditionally going to be a 24-2 visual field. That's what should be ran with most and almost all of the glaucoma patients. If it's a patient that has bad glaucoma where the 24-2 is blacked out and they can't see anything on that, then we're going to run a 10-2 visual field. With neurological stuff, we're going to run 30-2s, and sometimes you'll even run a 60-2. So the larger the number, the wider or farther out we're trying to capture that patient's visual field. When we look at types of visual fields, we have Amsler grids, which a lot of times for our macular degeneration patients, they're taking those home or we're doing them in the office. We have confrontational visual fields, which is an entrance test. And then we have our perimetry, which is your Humphrey field, your octopus, those types of fields that we talked about earlier. So leading off with Amsler grid, kind of some points here of use for this. This can be done obviously in the office. A lot of times these are sent home with our patients as well. So what we do with this is it's used to evaluate that central 10 degrees of the macula. So this is more of a gross evaluation. We're not going to get any numbers with this. The main thing what you're doing with your patients here and what they need to understand is, are the lines straight or are they not straight? And initially, if it's a patient that has macular degeneration and there is metamorphopsia, which is the lines being wavy, those need to be documented. That's the baseline. So circle it on their Amsler grid. If you send it home with them, they should stand about 30 centimeters away. Again, they need to cover one of their eyes. So they should do this each eye separately. And then have them document if there's additional metamorphopsia, or if it was a clean Amsler grid in the clinic, when they get home, have them document and circle it right on the piece of paper if there's wavy lines or metamorphopsia. And that's a way to just kind of track at home changes that could be happening in the macular region for these patients. You can see here on the right, this patient has some metamorphopsia. You can see kind of how the lines are wavy. Here, a normal looking Amsler grid in this situation. When we think of confrontational visual fields, I would obviously have you guys do this at home right now, but I can't see everyone. And when we're doing this together in our clinic, when I've taught this, we practice this. But again, key takeaways with this are it has to be done each eye separately. So have the patient cover their eye. I typically have them fixate on something on you. I like to have them fixate on my nose. You can see a little typo there. Use your eyes as a fixation target. It's a fixation target. So you can have your eye be the target. You could have your nose be the target. Whatever it may be, they need to focus on something. You could use a small bead and bring it in peripherally into their field like this. I like to use finger counting. So what I'll do is I'll say, how many fingers am I holding up? And I just keep it just outside their field and slowly bring it in. I'll do all different quadrants. So you can do, here. I like to do here. I like to do down here, down up here. And then I even come in from the side at times if I'm questioning it. But again, this is more of a gross evaluation. We're not going to get any specific numbers. We're just checking to make sure that there's no major visual field defect in one area or another. Good. So perimetry, this is what we're going to spend the majority of our time on. So we have kinetic and we have static. Again, kinetic is your Goldman perimeter, your tangent. Static is what we're going to spend most of the time on, which most of you do. What are our goals with this? Two different goals. Number one, we want to detect visual field abnormalities. Again, this could be for glaucoma. This could be for a neurological condition. This could be for a variety of reasons, but that's the main goal with it. The second thing is determine the progression of visual field abnormalities, and that goes towards our glaucoma patients. So we have a glaucoma patient that we're monitoring. We're trying to check for progression. We're trying to check the rate of progression, how fast they're progressing, and that's the majority of the reasons that we use this type of technology. The visual field really is trying to correspond with damage to the retinal nerve fiber layer. And remember, when we think of the retinal nerve fiber layer, there's different pieces to it. You have superior retinal nerve fiber layer, which runs up here. You have inferior retinal nerve fiber layer running down here. You have the papular macular bundle, or the macular retinal nerve fiber layer, that's kind of running right through here, okay? And then you also have nasal running out over this direction. Remember, the visual field will be flipped, meaning if there is superior retinal nerve fiber layer damage, the defect on the visual field will show up inferior. If there's temporal retinal nerve fiber layer thinning over here, the visual field defect is going to show up on the nasal portion. Same if it's inferior retinal nerve fiber layer thinning, the visual field defect will be superior. Nasal retinal nerve fiber layer thinning, you're going to see temporal visual field defect, okay? And that's just for you guys, for your knowledge. I don't know if you'll be tested on that or not, but it's nice to know that. The other thing to keep in mind, I'm going to show you a stat here in a little bit, that not always do these things match up, and quite commonly they don't. A lot of times, and the majority of the time, retinal nerve fiber layer thinning occurs before a visual field defect. And by definition, if there's a visual field defect present, we're already in the mild to even moderate range of glaucoma. So we do want to pick this up before a visual field defect most often. The problem is many times it's just not the case because, number one, patients don't come in all the time, unfortunately. It can be underdiagnosed. And then we run into other issues where we tell a patient, hey, come in a year, and they come in 3 years later and they have a pretty significant visual field defect. But just keep in mind, not always does structure and function match up. I just wanted to show you a picture of this so you guys had the knowledge of it. This is a Goldman perimetry. These take forever to do. Essentially what you're doing is you're bringing in a fixation target manually for the patient, and then you're documenting what they're seeing. And these things are massive. They're big. Some of you may be familiar with it. I couldn't even tell you how to do it anymore. I did one in optometry school and have since never done one, and hopefully will never have to do one ever again. So here's a visual field printout. So a few things with this, and this is again to think about reliability when you're doing these visual fields for patients. Fixation losses, false positives, false negatives, which are right up here, okay? You want those less than 15% or so, all right? If you see above 15%, then usually I'm a little bit concerned about the reliability of that field. Now, would I stop it? No, I probably would continue unless you're seeing fixation losses of 100% or 80%. But if it's around 15%, I feel pretty comfortable with that. You have to make sure you're putting the correct age in. Why? Because the correct age will help to stratify or go off the age-matched norms. It also will help with progression analysis. So the age is obviously crucial. You have to use the correct test. You know, we'll talk about CETA standard versus CETA fast versus CETA faster here in a second, and your doctor will order that. And then you have to use the correct near lenses. Some patients will need it, some won't. The beauty is the machine typically will adjust that for you. I'm just making sure there's not any questions in here. Good, one question, so no problem at all. So what exactly is a fixation loss? So fixation loss, when the visual field is going, what happens is there's a fixation point in there. And in most visual fields, it's a yellow type of light. And the patient needs to focus on that particular light. And if they deviate away from that, the machine is checking that. And so it's flashing a light near that particular light. And if the patient is missing that, and it's a bright light, and if they're missing that, then the machine's going to catch them wandering, okay? And it does it multiple times throughout the test. You can see in this particular example that fixation losses were 0 out of 13, meaning that a very bright white light was flashed at the patient very close to that fixation target in the field, and every time the patient picked it up, they clicked the button like they should. And so the machine is checking to make sure that they're accurately doing what they're supposed to be doing. The other question that I saw that popped up was, how do you document confrontational visual fields? And so typically the way that's documented is you document it as full to finger count, so FTFC, and you do it per eye. So when I'm doing it, I'll write FTFC, full to finger count, OD, comma, OS. If it's not full to finger count, then just draw on like this visual field is showing here. I would just draw draw a cross, and then circle or put a mark in the area that the patient is not noticing it. Okay, again, it's a gross evaluation. You don't have to be specific. Just document the area or shade in the area that they're missing. If it's normal, full to finger count or full to bead, whatever you want to write in that area. So another question that came up, how would you test for visual field loss with someone who is nonverbal, unable to test? You know, for a confrontational field, that can be challenging. You can definitely have them, when you bring the bead in, they can give you hand signals. So you can say, when they can see it, they can give you a 1, or just, you know, put a finger up, whatever you want to do there. The beauty of the visual field is they don't have to be verbal during it, because again, it's flashes of light. So they're able to go ahead and do that without verbal confirmation on that. I love all the questions. They're popping up like crazy here. This is great. Yeah, so another question, when having a fixation loss during the test, you can pause to reposition, correct? And that is correct. You can pause it. You're probably asking the wrong person how to do it, because you guys probably have a better understanding, but I believe all the patient has to do is hold the button in and it'll pause it, or if they communicate to you as the technician, there's a pause button right on the screen where you can pause it there as well. Another question, is there any reason why we would do a Goldman perimeter rather than Humphrey? In my opinion, no. There are still some workman's comp cases, things like that, that require a Goldman perimetry. And so you'd have to send it to someone that has that. And that's more dealing with, you know, a lawsuit or something along those lines. But most of the time, it's going to always be a Humphrey visual field. last question here, and then I'll move on. It's a good one. How many times do you restart the test due to fixation losses before you just let the patient continue? So as I kind of mentioned earlier, if the fixation losses are right around 15 to 20%, you're going to see that in front of you. You're going to be able to monitor that. I just let the patient keep going. If that number gets way up and I'm above 50% or I'm seeing 80%, I'm going to go ahead and stop the test. If you're a long ways into the test, it may just be worth abandoning it and repeating it down the road. If you're only a minute into the test and they already have 80%, or you're 2 minutes into the test and they're 80% on the fixation losses, I would restart it and do it again. So keep in mind that, a CETA fast, for example, or CETA faster only takes 3 to 4 minutes. It's very quick, and sometimes even faster than that. So you are able to pause it or start it over and still not waste a bunch of time. Good. So you can see the times down there. So CETA fast, 3 to 5 minutes, CETA standard, 5 to 9, full thresholds take 8 to 15. So I do want to touch on that a little bit on the timing of these things, because there's a new in the Humphrey Visual 3, there's a new software system out, and it's the CETA faster system. And I'm going to back up. When you look at the bottom here, the CETA fast, which is the one that we traditionally do, takes about 3 to 5 minutes. Some glaucoma specialists would say you got to do CETA standards with 5 to 9 minutes. My argument to that is I'm willing to do a faster visual field because it's going to be more accurate and lose a little bit of the data versus doing a CETA standard, which is going to take longer. I'll lose some data by going to fast, because standard's going to cover more of the data, but I'm going to have less reliable visual fields. And so we've always done CETA fast on our patients. We now have transitioned to doing CETA fasters. And the reason being is it's 50% faster than CETA standard, and it's 30% faster, okay, than the CETA fast. And with that said, you don't lose any data if you've already been doing CETA fast to go to CETA faster. You lose 0 data. Now, if you go from CETA standard, you are going to lose some data. But again, my argument to that is you'll get more accurate and more consistent visual fields. You do have to have the Humphrey Visual Field Analyzer 3 in order to get the faster, but you can update that if you have the Humphrey Visual Field 3. So I'd encourage you to think about it. You have to talk to doctors you work with and stuff. CETA fast does a nice job. We really like faster just because, again, it's faster, works quicker, and patients are more in tune with it and enjoy it more so. And then the question that just came up is, out of all the different tests, which do you feel is the most accurate? It's a tough question. I think they're all really good. I think the standard, in my opinion, continues to be the Humphrey Visual Field. The Octopus does a really nice job as well. But CETA, the Humphrey Visual Field has just been such a solid workhorse visual field for so long. And you can do so many things with it, especially with the technology that they've brought out with the CETA Faster now. They now have something called 24-2Cs. And what that is, they're testing an additional 10 visual field points in the central visual field, which is important. So, I lean more towards that particular one, but I think Octopus is a nice visual field as well. And then you have your screening tools out there also. FDT is a good screening visual field, not ideal, in my opinion, for long-term management of glaucoma patients, but an excellent screening tool to use in a practice that, maybe you're running patients through a pre-testing area. So excellent question. So I did want to share with you guys something that's interesting. I've had a chance to use this a bit in practice now, with all the COVID-19 stuff and the at-home stuff that we're trying to think about, the telemedicine stuff. This is a virtual reality visual field instrument that is produced by OLEYes, and it's called Visual. This was a paper that was presented at the American Glaucoma Society meeting this year, and they really showed very similar results to the Humphrey Visual Field system. You can see a printout over here, which shows that the printout is very similar to a Humphrey Visual Field. I've had the opportunity to run this on a few patients of mine. This is one of my technicians on here, so I'm not violating HIPAA, I promise. Cole would be okay with this. But the beauty of this is it really does match fairly closely to the Humphrey Visual Field. The patient does not have to be obviously in a room. They can be anywhere. They can sit in an exam lane. They can sit in your waiting room. They can tip their head up, down, left, right. Very easy to use once you understand it. They're coming out with a home edition as well, where patients will be able to have a home edition, so visual fields be done at home. I've been impressed with the reliability. I've had patients that I've had done the Humphrey visual fields, and then I had them do this, and they've matched almost simultaneously. They look, almost perfect. Now, I don't think this is going to necessarily take the place of our Humphrey visual field, but it's an option for patients that maybe have mobility issues that can't get their head in the visual field, patients that don't do well with the visual field. One thing to point out with this particular test is it is a little longer than the CETA Faster and the CETA Fast, but they recently just made some changes to it, and they've increased or made the testing time much shorter. And so I think this instrument or this technology has a place in our practices, and it'll be interesting to see kind of where it goes. So another question here, how long does the CETA Faster usually take? It's about 3 to 5 minutes. So good question. It's about 3 to 5 minutes to get a CETA Faster done. And actually, my apologies. I'm sorry. You asked about CETA Faster. CETA Fast takes 3 to 5 minutes. I'm going back to the slide for you. CETA Faster can be, I mean, I've seen it as fast as, a minute and a half. It could take up to 3 minutes. It depends a little bit on the visual field defect as well. So the Faster could take 5 minutes if it's a patient that has moderate glaucoma, but it's about 30% faster than CETA Fast. So keep that in mind. So anywhere from, I've seen again, as fast as a minute and a half to 2 minutes up to, it could take longer than that. So I apologize, I answered your question incorrectly there. You guys are rocking the questions. They are flowing in right now. So sorry for the pause, but I feel like I want to do these more than go through my slide deck because they're better. Yeah, so the name of the virtual visual field is called Visual. So it's spelled V-I-S-U-A-L-L. It's from a company called Olleys, O-L-L-E-Y-E-S, if you're interested in looking that up. So that's the name of the company. Another good question, how do we motivate patients that need a visual field? Not easy to do. Visual fields are not fun. I think knowing what I mentioned earlier with CETA Faster being available, that's motivation alone, telling the patient, guess what? You don't have to put your chin in that machine for 10 minutes anymore. You're going to be able to do it. Even if you're using CETA Fast, you're going to be able to be done in 3 to 5 minutes. The other motivation is just to remind them that this is a crucial test for us to monitor or pay attention to something that is visually threatening. You can lose your sight from this, and we're doing everything we can to prevent that. This test is just crucial to have that done. And so those are probably a few of the things that I would mention. And you're exactly right. The feeling on visual fields is negative. Patients don't like to do it. And that's one of the reasons why, the slide I have up here is why this company came out with this visual field system. It's comfortable. A patient could be sitting in an exam chair, or they could even be sitting in a lounge chair in your atrium and have this on and take a visual field. They could be sipping on coffee or drinking some water while they're taking the field. And so part of the reason this company was started was to kind of get away from that negativity on visual fields. So really good questions. Okay, so let's keep rolling here into the advantages of the Humphrey visual field. So this is what a printout looks like for a Humphrey visual field. We'll get into that in a little bit here in a second. One advantage of Humphrey is they have a great guided progression analysis. And so what you need to do guided progression analysis is you got to have 5 visual fields. So you have 2 total baseline ones, which are these over here. Okay, these are your baseline visual fields. And then you can see 3 additional fields over time. And the time doesn't matter. In some patients, we may be getting them every 3 months because we're trying to figure out how aggressive is their glaucoma. Sometimes it takes years for us to get those additional 3. But once we get the 5 visual fields, then we get into this progression analysis graph, which is really nice. So you can see this patient has 5 visual fields, and their line, or that slope, is straight across. Okay, and I'm going to use a little different pointer here. So that line right there is straight across, meaning that patient isn't progressing. If you see the line going down like this, that means that patient is progressing, and it actually gives you a rate of progression confidence. So it's very useful for us to monitor patients long term. we still have to look at the defects and we still have to grade these and watch individual points. But this is a nice way to, number one, educate patients, but number two, get a big picture look at, is a patient progressing or not progressing? So key points that we pay attention to: data needs to be trustworthy. So for you guys as technicians, this is a huge piece for us. We have to have the date of birth right. We have to have the right test in there. We have to make sure the patient is looking where they're supposed to be looking, that we get the right type of data. That's crucial. A lot of times we're going to need 3 to 4 tests to achieve a baseline. The first test isn't always going to be ideal. We may need to bring the patient back multiple times. And then does it make sense with other findings? Because a lot of times in glaucoma, it can look like glaucoma, but it could be neurological. And so as a doctor, we have to really watch and make sure that it doesn't make sense with other pieces of the testing. Does their optic nerve head match with the testing they're showing? Does the retinal nerve fiber layer match? Does the patient have, what's their intraocular pressure? There's so many different things that we need to look at there. And this goes to the repeatability point. This is some data looking at it that 86% of the time when a visual field was done, it was not confirmable on a retest. So there's a lot of variability. That's why getting 3 to 4 visual fields on a patient is important, to really establish that baseline to determine, are they progressing? Do they truly have glaucoma? And it's not always feasible to get that many visual fields, but we try to. We try to get it before we make an ultimate decision on that. So artifacts, this again goes partially into your guys' realm of what you need to pay attention to when you're doing these visual fields. Pupil size, refractive error, are they wearing, how long have they been wearing contacts? You know, if we put the wrong birth date in, is the patient cooperating? Are they dry? We put in cooperation twice. You know why I put it in there twice? Because that's usually the biggest issue. Eyelids, the rim artifact. I'll show you a picture of that in a second. Do they have some other types of pathology? Retinal disease? All this stuff can affect our visual field. And so, you know, big things to pay attention to. Lens rim artifact. You know, this is where you're doing the visual field. You have to make sure that that trial lens is really close to their eye, because what you'll get in that situation is a field that looks like this. You have rim artifacts going all the way around. And this is not a visual field defect. This is coming from the lens. And so, you know, when we see this, we know that it's an inaccurate visual field. So really getting that lens up close to the patient's eye, having the right angle so that they don't pick up any of that. You want to try to get it as close as possible to not touch their eye, but also if it's too far away, then we'll see these types of rim defects, and we're trying to avoid those as much as possible. Good. So real quickly, I'm not going to spend a lot of time on this, but it's just nice to see this, because if you see this documented in the chart, it's nice to know about it. So when we grade visual fields, we grade them as mild, moderate, or severe. We then will add mild primary open-angle glaucoma, or mild pigmentary glaucoma, or mild traumatic glaucoma, or mild pseudoexfoliative glaucoma. So we label them on that level. And then on top of that, we'll label the type of defect. You'll see that here in a second. We'll label it as a mild primary open-angle glaucoma nasal step. So you'll see all those here in a second. So with mild, in order to fit into that, and don't memorize this, but just have this as knowledge, to be labeled as mild, all 3 of these things have to be met. And this is adopted from the HODAP Anderson Parrish visual field criteria. You have to have a mean deviation less than -6. You have to have a PD plot, okay, less than 14 points. And I'm not going to read that. And then you have to have no central points. And so if you look at the visual field over there, I circled in red all 3 things that come into play. Over here is where you find your mean deviation and your pattern standard deviation. So this area corresponds with these 2 right here, okay? And then the central points, you would look right here to look at those decibel levels, looking at the sensitivity on there. In regards to moderate, mean deviation falls between -6 to -12. Same thing, okay? A little higher number. The PD plot, you can see it there, 1 central point less than 15. And then severe, greater than -12, and you guys can read that as well. Now, when we're dealing with moderate and severe, you only have to have one of these things to satisfy to be classified as that. So with mild, all 3 of these have to be met. With moderate and severe, only one of these need to be met. And I'm happy to share these slides with anyone. If any of you guys are interested, don't hesitate to reach out to me. Happy to share these slides at any point with you guys as well. Okay, trying to look at Q&A every once in a while. So getting a few questions about a copy of the slides. No problem. If anyone wants slides, please don't hesitate. I'll get them to you. That's not an issue now. You can reach out to Melissa, Jamie. They'll get them to you as well. So happy to do that for you. So here's what I talked about earlier, looking at the different types of defects. So you have a paracentral defect, a nasal step. This is just what's going to be documented in the chart. More so, do you have to know this? No, but I want you to be aware of it so that if you see in the chart a mild POAG with a nasal step, you understand what that looks like and what it shows. So these are the different types of documentation that we use quite often when we're dealing with visual field. All right, so what matters in glaucoma? I've listed this because we're going to dive into a little of this, but the 7 things I really care about in glaucoma, I want to know their family history. A patient that has any family member that has gone blind from glaucoma, I'm going to treat those patients differently than I would someone that has not gone blind from glaucoma. And we use the word blind. I think that's important because there's different types of glaucoma. There's bad glaucoma that causes people to go blind. And then there's nice glaucoma that doesn't cause people to go blind. Both need to be managed, but one needs to be managed more aggressively than the other. So we ask that question. Pachymetry is corneal thickness. Thin corneas, based off the Oates study, is a risk factor, an independent risk factor for glaucoma. So it's a risk factor profile piece. We know IOP matters. High IOP is a risk factor for glaucoma. There's plenty of normal tension glaucoma or normal IOP glaucoma out there, but we know that high IOP is a risk factor for glaucoma. It's really the only thing we can treat right now in glaucoma as well, is we always try to lower IOP. Optic nerve head cupping matters, paying attention to that. The OCT, the visual field, and then finally corneal hysteresis, which I'll touch on when we get into measuring tonometry here in a second. I mentioned this earlier, but I wanted to mention it briefly now to you as well. Remember earlier when I said not always does structure and function match up. Not always does the visual field match the optic nerve head OCT or the retinal nerve fiber layer thinning. This is some data showing that 55% of the time there's changes happening to the disc and there's nothing happening to the visual field. 35% of the time visual field changes happen, okay, and we're not noticing or seeing it on the disc, and 10% of the time it's both. So there is some variability there. We can't always match both of these up at all times. So this is not, I definitely don't want to get too complicated with this. This gets into the more of the neurological component of things. And this is a challenge because glaucoma a lot of times will mask or look like something neurological. My take home from this section, when you're doing a visual field and you look at the printout and you're going to obviously have the doctor take a look at it, is if you see something that is bilateral and consistent, okay, you have to think neurological. And so what I mean by that is if you see a visual field defect that's only in one eye, so like this one, number 1, that means it's in front of the optic chiasm. So it's affecting just the optic nerve head of the right eye in this particular example. Or if it was blacked out on this, it would be affecting just the left eye. So number 1 is an example of this could be glaucoma, okay? Or it could be something on the optic nerve head, all right? But I'm much more confident when it looks like this that it's glaucoma. If you see anything like 2, 3, 4, 5, or 6, okay, you can see it's in both eyes and symmetric, all right? This is much more likely and very likely neurological in nature. Okay, this is a red flag that there's something going on in the brain. What? Could be stroke, could be a lesion, a variety of different things. You know, you don't have to know where it's affecting it in the brain. I don't care about that. This should just be a trigger that, hey, something's going on in the brain. It's probably not glaucoma. This patient needs something, more from a workup standpoint. Okay. So I'm going to stop there on the visual field piece of things. I think we have about, 20 minutes or so. I'll probably end a little bit early from that. I want to talk a little bit about P. Any other questions? I'll just check the question and answer here. So a good question, fogging with masks on during visual field. It depends. It's tough. My technicians probably would have a better answer than I do because again, I don't do the visual field. That's why I depend on you guys so much and have so much appreciation for it. I suspect you're asking because when the trial lens is so close to their eye, the mask is causing that to fog up. You can pause the test, have the patient sit back, of course, that would be one option. They definitely have to be wearing masks right now. And so there's no solution there on removal of masks, that these patients should be wearing masks. I guess my suggestion would be to get the lens as close to their eye as possible. If it begins to fog up, you're going to have to monitor that and have the patient pause the test quickly and have the patient sit back. That's where, the virtual reality visual field goggles have been, kind of fun and nice. You don't have to worry about with those. You don't have to worry about putting a trial lens in there. You don't have to worry about fogging up. And so that's been a really nice addition. And that's why I don't think it'll take the place of visual field, Humphrey visual field, but I think it can serve a purpose. All right, IOP. So obviously intraocular pressure is the one modifiable risk factor we have when we manage our glaucoma patients. There's plenty of data out there that IOP matters. The Baltimore Eye study, as you can see, the higher the intraocular pressure, the more likely or the higher the prevalence of open angle glaucoma. Interestingly enough, though, when we look down here at the bottom, in this particular study, which was around 10,000 eyes, 20% of the patients or so had what we would consider, normal tension or low tension glaucoma. So they had normal IOP, but still had glaucoma. So we as doctors have to be very careful that we don't get caught up in just looking at IOP. I try to tell myself that every time when I'm looking at a patient that has, suspicious visual field, suspicious optic nerve head, and then they have an intraocular pressure that is normal. Could it be glaucoma? Yes, it definitely could be. There is prevalent studies out there showing that. IOP can be a tough apple to hit. Unfortunately, getting measurements is tough. There's a lot of inaccuracies with a lot of the testing that we do right now. When we think of influences IOP, the central corneal thickness matters. A lot of our patients have undergone, a refractive procedure that's thinned their cornea out. When we applanate those patients, we're probably not getting an accurate visual field. The tear film affects IOP measurements with applanation tonometry, which is what we're picturing right here. This is Goldman applanation tonometry. The tear film affects it. Thin corneas versus thick corneas affects that. A patient that has a real thin cornea is going to have a lower intraocular pressure. Well, that's probably not true. Their pressure is probably higher than what we're reading. Someone with a thick cornea is going to have a really high intraocular pressure, but it's probably not that high because the thickness is tricking us. I mentioned post-refractive. The time of the day matters. We know from studies now that intraocular pressure is highest in the mornings and decreases during the day. So you have a diurnal intraocular pressure. Medications, patients that are taking topical steroids will have increased intraocular pressure. Oral steroids can increase pressure. Oral beta blockers can lower intraocular pressure. So a variety of different reasons there. And then of interest lately has been this physical posture stuff. So I don't do yoga. I have no idea how to do it. I probably should learn. I'm not getting any younger. And I've heard good things about it, but there's studies out there looking at yoga that patients that do yoga, there's an increase in their intraocular pressure of 11 to 12 millimeters of mercury in different yoga positions. Interestingly enough, though, it goes away within 1 to 2 minutes, thankfully. And so to me, that doesn't probably matter unless it's a patient that has very severe glaucoma. If they have bad glaucoma, then I may encourage them not to do yoga because those pressure spikes could affect it. If it's mild glaucoma, moderate, I'm not worried about it. The other thing is aerobic exercise. We now know that exercising for 30 minutes a day can lower intraocular pressure 4 to 6 millimeters of mercury for about 3 hours. It'll go back to their baseline, but for those 3 hours, it's lower. So if a patient comes into the office, they have been exercising, there is the potential that we're measuring their intraocular pressure a whisper lower than it typically runs, and that can throw us off. So with that said, there's a lot of different ways to measure tonometry. We have rebound tonometry, which is right over here. Okay, this is rebound or an eye care tonometer. We have a tono pen. We have our traditional applanation tonometer. There's NCTs out there. This is a handheld one. And then you have your on the table NCTs. The ocular response analyzer from Reichert, I'll touch on in a little bit, also gives us pressure as well as corneal hysteresis. And then there's a new tonometer on the market. This was launched in October. This is called the CATS tonometer, or the correcting applanation tonometer. This fits right into the housing unit of your traditional Goldman applanation tonometer. So it goes right in this section right here. This tip comes out, okay? And then this tip will go in there. And what's different about this tip is its design right up here in the front. So instead of being concave going out, all right, it's convex. So it's coming inwards. And the reason for that is it's trying to match the shape of the cornea to reduce some of the issues that happen from the tear film that give us inaccurate IOP measurements, and to take care of a lot of the biomechanical properties of the cornea or the rigidity of the cornea that throws off IOP measurements as well. And so this has been studied versus Goldman applanation tonometry versus rebound tonometry. They've studied the true IOP inside the eye, where they actually put a little tiny needle in the eye and know exactly what the pressure is, and then they take a measurement with this. And it appears, based off the data, that this is the most accurate way to measure pressure. Again, user preference, meaning if I don't do a good job of getting this on the eye and getting a measurement, or the patient isn't doing a good job, that's going to throw out the results. But if in a perfect world, this is probably the most accurate way to measure pressure right now that's on the market. And then there's corneal hysteresis. Corneal hysteresis is a small air puff test, and it's measuring the ability of the cornea to absorb or dissipate a force. And we know from multiple studies across the board, there's tons of them out there, that a low corneal hysteresis, meaning 9 or lower, okay, is a risk factor for glaucoma. It's a risk factor for glaucoma progression. It's a risk factor for the rate of progression of glaucoma, so, and how fast it progresses, okay? So a normal corneal hysteresis in the United States is about 10.5. Anything above 10.5 is considered normal to high, and that's a good thing. Anything down around 9.5 or below is considered a low corneal hysteresis, and that's a situation where it's a risk factor, and I'm concerned about that. Great question. Does the CATS tonometer give the same pattern as Goldman? It does. And so initially it looks exactly the same way. It's a little tricky the first couple times you do it because it's very sensitive, but once you do it a few times, the pattern's exactly the same and you become very proficient at it. So no learning curve with it, except initially getting it on the eye correctly is just a whisper trickier at first because it's a new device. But the pattern looks exactly the same. So thanks for that question. That's an excellent question. This is what the Aura printout looks like. You can see here that you get an IOP, so IOP-G. You get an IOP-CC, which is a corneal compensating pressure. What I really like about this is the CH though. Again, corneal hysteresis, as I mentioned, and this patient was 11.2. Just a risk factor profile measurement, making me feel more comfortable that this patient is at less risk for glaucoma. So that leads me into talking real briefly about non-contact air puff tonometry in the world that we live in today, with the fears that, are we spreading, COVID-19 by doing non-contact air tonometry? And if you do a literature search, there is really nothing out there that's published except for this particular study in February 1991. There's a lot of stuff out there right now saying that, yes, it can spread. I am of the belief right now that there's not enough data to say one way or the other. So I'm not sitting here saying it does spread by doing air puff tonometry or it doesn't. What I'm referring to here is just the one study that I'm aware of and that I've found doing my research. And in this particular study, what the investigators found is they documented visible tear film splatter, or what they term is micro aerosol, micro aerosol or particles in the air. Now, the concern that I have with this and others have with this particular study is, in order to look at a microaerosol to be truly classified as microaerosol, that's equal to 1 micron or smaller in diameter. Okay. To be able to visualize that with any type of technology, 40 microns is the visual threshold. So I believe what they're terming as microaerosol is probably inaccurate. They're probably seeing something, but I don't think it's probably a microaerosol. And that's really what matters when we're doing non-contact tonometry and we're worried about spreading COVID through the tear film, okay, through that microaerosol in the air. So I'm not convinced that it really matters, okay? And again, you'll hear different things, but there's truly no real good data out there showing that it can be in the air based off non-contact tonometry. What also is interesting in this study in 1991 is they used a type of tonometer that really blew a puff of air in the eye. So a very strong puff of air. None of the tonometers on the market puff that strong of air anymore as what was done in this particular study. So they used a Keeler device back in 1991, and it made patients jump. Still makes patients jump today, but the puff of air is much lighter. Okay, so with that said, you practice have to make decisions based on this. But we're going to continue moving forward with doing Aura, our ocular response analyzer, that does a little puff of air, because there's just nothing right now that really supports the fact that we shouldn't be doing it. So for us, we like corneal hysteresis to help serve a risk factor profile, IOP, and central corneal thickness. All of these things matter to us in glaucoma. There are IOP home monitoring devices. So the iCare Home is out there. We have utilized this a bit. I think this matters in more of a telemedicine, telehealth world that we may be living in for a while. And so these can be purchased. We rent them to our patients is how we do it. Patients can get them if needed. But how well utilized are these going to be? I'm not sure. But we do utilize these. We have 2 of them that we utilize and rent out to patients. And then I think the future is going to be continuous IOP sensors. These things will obviously either be contact lenses or something implanted inside the eye. This is an implant data. So this is implanted in the sulcus. You can see it in this patient right here. And this is continuously pumping out IOP data. And we know exactly what their pressure is at all times. And so right now, nothing in the United States, but I think eventually we're going to see that. And then I just want to end with this piece of it. Remember, if you are applanating in your clinic, which I know many of you are, this is really what you're looking for, all right? Here's the perfect one right here. This is how you want this to line up. This is with the CATS tonometer as well as traditional applanation tonometer, okay? This would be if you're overestimating, and this would be if you're underestimating. So your whole goal is getting this alignment right here, okay? Couple tips. There's drops that already come with fluorescein that have some numbing agent in it that many of you are probably using. We use a fluorescein strip and put a drop of proparacaine on there, and that's how we do it. Either way is fine. I always give the patient a fixation target. Don't put any pressure on their eye because you're going to artificially read their intraocular pressure too high. And then just practice. Practice it over and over again. Maybe use a non-contact tonometer to check yourself, or have the doctor check you. Make sure though you numb the eye. Obviously that's a key piece. Your patients will like you better. But practice, and it becomes second nature at some point with doing that. So I'm going to spend 2 minutes on tip cleaning. So this comes from the American Academy of Ophthalmology with tonometer tips. They are recommending or mentioning that single-use disposable tips, if available, are probably best. But as you'll read this paragraph here, 70% alcohol solutions, so a lot of the swabs that we all have, the isopropyl alcohol swabs, are effective in disinfecting the tonometer tips for COVID-19 and the SARS-CoV-2. The issue is it can damage the tonometer tip, so keep that in mind, but it's still worth wiping it down, obviously, between patients. Some of you probably are using diluted bleach, and that still remains a safe and acceptable practice. And this is according, again, to the AAO as well as AOA. So from a tip standpoint, isopropyl alcohol, disposables are good, or diluted bleach to continue to treat the tonometer tips. And then I'm going to throw up 3-4 studies, because a question that I've gotten a lot over time here is, can this be transmitted through the tears? Can it be transmitted from the conjunctiva? How careful do we need to be? So I'm going to throw up 3 studies, and you're going to see a common theme with all 3 of these studies. And the common theme is that patients that presented with conjunctivitis, okay, that came from COVID-19 were much more likely to have it found in their tears or on their conjunctiva, but the percentage is super low. So here's the first study, February of 2020. These were 30 patients. They tested all 30 of them. 29 of them, as you can see, tested negative to conjunctival and tear testing. 1 tested positive on the conjunctival swab. That 1 patient was the only patient that had a conjunctivitis, that had a red eye when they came in. The other patients did not have anything in the eye, okay? We look at this study published in the New England Journal of Medicine. So researchers out of 1,000 patients only documented 9 that had what they considered conjunctival congestion or redness of the eyes. So that's 0.8%, all right? This was 30 hospitals across China. Now, they didn't do tear samples, which would have been very, very interesting, but they noted were they red or not. And so a very low percentage of patients with what appeared to be a conjunctivitis in this hospital setting in this particular study. We look at this study published in February of 2020. These were 72 patients confirmed with COVID-19. This was in China again. 2 out of the 72 had conjunctivitis. 1 of the patients with conjunctivitis, okay, had it found in the tears when they took a sample, and 70 of the patients that were diagnosed with COVID-19, none of it was found in the tears. So again, very low percentage in the tears. Okay, again, one of the patients with conjunctivitis, it was found, which makes sense. And then the final study, 63 patients with COVID-19, 1 had conjunctivitis. That patient had a negative conjunctival swab. Okay, 1 other patient's conjunctival swab was positive, and 2 were probable. Again, my point being with showing you these particular studies is that yes, there's the potential there. If a patient comes in with a conjunctivitis or red eye, we need to be asking them about other symptomology that could be indicative of COVID-19. But the likelihood of this being in the tears and in the conjunctiva and passing it is still pretty low based on the data we have right now. That could change as we get more and more information, but this is the data we have up to this point in time. So I'm going to end there, guys. We are, I think, just a few minutes shy of 1 o'clock. I'll just double check any questions that have popped up. Question, are we doing visual fields now during COVID-19? We are doing visual fields. You know, our practice has a very, heavy glaucoma population. And so we are utilizing the virtual reality visual field that I showed you guys earlier on patients. Our patients are wearing masks when they do the visual field. Obviously, we're disinfecting everything. We're not disinfecting the bowl right now, but Zeiss just came out with a protocol of how to disinfect the bowl of the Humphrey visual field. So if you don't have that, I can share that with you guys. I have that in hand, and we are going to implement their, we'll implement their recommendations because they know how to do it without ruining the equipment. So that's currently the protocols that we're following with that.
Thank you so much, Dr. Schweitzer.
Well, I will, yes, you bet. So I didn't see any other questions. I was checking one more. There's nothing there. I sure appreciate everyone's time. Really enjoyed going through this with all of you. We'll make sure if anyone wants the slides, we get those to you. And have an awesome weekend. It's going to be a little chilly here up in Sioux Falls, but the sun's shining, so that's the main thing.
Thanks, Dr. Schweitzer. Just a few closing remarks with regard to the credits. Please be sure to sign out via the chat to take attendance. And then the quiz link has been emailed to you. And so that will be, needs to be completed by Tuesday. And I will still be issuing the credits for last week. Hopefully this afternoon I'm going to get to that. And so you should have the credits for last week's session here, hopefully by the end of the day. If you have any questions, please reach out to me. My email is in the chat, Jamie Anderson, jamie.anderson@VanceThompsonVision.com. And we will resume our sessions on Monday at noon. Thanks so much, and we hope to see you next Monday.